I would like to thank you for the organizing committee for the opportunity to present our paper at World Congress of Endoscopic Surgery. My name is Dr. Iswanto Sucandy. I'm HPB Chief at Advent Health in Tampa. My topic will be a propensity score match analysis of robotic versus open hepatectomy for treatment of liver tumors, a comparison of clinical, short-term oncological outcome and cost. I have no disclosure to report. Robotic hepatectomy is gradually becoming accepted in high-volume liver surgery center. The robotic approach is associated with increased ergonomics, improved visualization, ease of suturing, ease of hemostasis, which lead to lower blood loss and conversion rate, as well as increased precision. Published data is limited in robotic liver surgery. Therefore, we designed a study to compare robotic versus open hepatectomy, focusing on the quality of oncological resection, clinical outcome, and cost. We have 285 consecutive patients undergoing robotic versus open hepatectomy for neoplastic liver diseases. For the purpose of this study, we excluded the benign disease. The study encompassed a period of 8 years from 2012 to 2020. We propensity score matched the patient using 1-to-1 ratio based on the following factors. We performed statistical analysis using standard tests as listed above. Data are presented as median, mean plus minus standard deviation. We also utilize Kaplan-Meier survival curve for evaluation of the overall survival between open and robotic approaches. The result: we have 285 patients who were included in the study. We have 34% of patients underwent open hepatectomy and 66 patients underwent robotic hepatectomy. After propensity score matching, we have 49 versus 49 patients. We found that both robotic and open had similar blood loss as well as similar operative time. However, the operative complications is lower in robotic. The length of stay is shorter in robotic. Distance to margin is increased in robotic with similar R1 resection rate. As we can see here, postoperative complications favor robotic, length of stay favor robotic, distance to margin also favor robotic with similar R1 margin. This is a further dive into the study before matching and after matching. You can see here in red, before matching, there's differences in MEL score and Child-Pugh score. However, after matching, they are both become equal. This is the interoperative variable between open and robotic. You can see the operative duration, size of tumor, margin status, type of liver tumor or pathology, HCC versus intrahepatic cholangiocarcinoma versus colorectal liver metastasis versus others, blood loss, percentage of minor versus major resection are all equal between robotic and open. However, the distance to margin has actually improved with robotic, 5 mm versus 2 mm. Further to postoperative complication, you can see here the length of stay is actually shorter with robotic, 4 days versus 6 days with open, and it reached statistical significance with p-value of 0.002. We also have lower postoperative complications for 90 days with clavio more than 3, favoring robotic approach with p-value of 0.02. This is the Kaplan-Meier survival curves comparing the long-term overall survival at 5 years between robotic and open. The first graph on the left is for colorectal liver metastasis, which showed equal long-term oncological outcome. The graph on the right showed survival for hepatocellular carcinoma, which also showed equal outcome between robotic and open at 5 years. We also added financial analysis of cost, which included total hospital charges, total cost, variable costs, fixed direct costs, fixed indirect costs, reimbursement received by the hospital, as well as contribution margin. You can see here that the total cost between robotic and open are actually equal, about 30,000, despite robotic being perceived as a more expensive option. However, it's actually equal cost versus open. The hospital reimbursement, however, is lower with robotic, with only 20,000 versus 33,000, which was received with open. And we explain this as robotic being a newer approach with CPT code, which is still not established in America for the insurance company to pay for the service done robotically in HPV surgery. However, this is something that will be different in the future as robotic become more commonplace in HPV surgery. The conclusion, the postoperative complication and length of stay were lower or decreased with robotic hepatectomy compared to open. Oncological outcome, however, were not inferior with robotic hepatectomy. Both approaches led to similar costs. However, hospital reimbursement is actually lower at this time for robotic hepatectomy due to the newer CPT code. This is the end of our presentation. Thank you very much for the opportunity to share our data from Advent Health Tampa.